Today's module is on shoulder labral tears. The problem with this diagnosis is that it often goes undiagnosed, and patients can have significant problems without getting an adequate diagnostic or treatment plan. Another important part of this diagnosis is to make it definitively, one needs to get a shoulder MRI, but with contrast, so-called arthrogram. That turns out to be more sensitive for detecting labral tears in the shoulder than just a regular MRI. So a number of times, primary care providers, for example, will not be aware that they need an arthrogram in order to make this diagnosis. If they have a better clinical suspicion from their exam room maneuvers that it's a labral tear, they'll understand they need to get an arthrogram when they get the MRI scan. And the benefits, again, are being able to get treatment early and specific treatment, as well as for patients who are not improving, getting them a surgical referral if needed. Okay, so for shoulder labral tear, usually there's a specific trauma, such as an outstretched arm. In my patient population, a number of whom have been in motor vehicle crashes, maybe the arm is outstretched during the crash on the steering wheel, or there's direct impact on the shoulder against the car door. In the throwing athlete, this may be a gradual injury. Not my patient population generally, but well established. Patients often feel like there might be a clunk or a sense of instability in the shoulder. It's a pain deep in the shoulder. Most shoulder impingement, the pain is out here, but for labral tears, it's often very deep in the shoulder, worse with reaching and overhead activities. You want to be able to distinguish this from other diagnoses, such as thoracic outlet syndrome, which often causes problems more down the arm, or impingement syndrome. Physical exam, you'll typically find, and again, as I've done with all of my other modules, for physical exam, we would actually always start with the neck first. Just do a very simple screening exam that's covered elsewhere. Why do we do that? Because if someone presents with pain here, it could be the shoulder, or it could be a cervical radiculopathy with pain, radiating into the shoulder from a neck problem. But let's assume you've done that, and now you're putting the shoulder through range of motion. There might be a sense of pain deep in the shoulder. There may be, when you do Hawkins tests, some pain deep in the shoulder. But the physical exam maneuvers that help clinch the diagnosis are, for example, something called the O'Brien test. And that's where the thumbs are down, patient holds the arms up, and that causes a deep pain in the shoulder, often a little bit better with the thumb up. Very specific for labral tear. There are other kinds of labral tests, grinding into the shoulder and that sort of thing. The other test I sometimes do is called the speed test. And the arm is outstretched like that, supinated, pushed down, and the patient will get anterior shoulder pain. That also goes with biceps tenosynovitis, but those two can go together because the long head of the biceps tendon, which I will show here, anchors to the top of the anterior labrum. So they often can go together, actually. Finally, for labral tears, there can be an instability of the shoulder. And the classic way you test that is something called the apprehension test. You might do it with the patient sitting up. But typically, you really have to do it with the patient supine or lying down. So Jennifer, if you can lie down for me. And what happens with the apprehension test, it really has two parts. One is you're bringing the arm out, about 90 degrees abduction. And patients will often get apprehension and or pain, usually more apprehension but also pain, as I start to crank the shoulder into more external rotation. So it's often uncomfortable for them and they have some alarm. If I reduce the shoulder by putting some pressure on the shoulder anteriorly, they often feel that helps them and it's not as painful or does not cause as much apprehension. And that's because when you have a labral tear, there can be anterior instability of the shoulder, and this helps sort of keep the shoulder back in its socket. That might be classic with, say, someone who's had a history of a shoulder dislocation. Some people believe that patients who are hypermobile, such as so-called EDS patients, Ehlers-Danlos syndrome patients, they might be more prone to labral tears or at least to shoulder instability. Treatment can include physical therapy early on. If that's not helpful, we often look at PRP in our clinic, injections of platelet-rich plasma. We would typically not just get a shoulder MRI scan, but as I discussed elsewhere, a shoulder MR arthrogram. Arthrogram uses contrast to highlight the labrum better within the shoulder. And if patients fail these various non-surgical treatments, and depending on their goals and their findings, we would make orthopedic surgical referral.